Jamie's turn on the camera.
Everybody can take their seats, please.
Good feedback.
The Lord has spoken in his deck mic.
Look whether he's going to give it to us. Table. All right, I'd like to call the policy procedure. That's not going to work.
Wow. Wait.
Move them back, maybe?
Put it on the table up here.
Let's move the table back. Here, toss it back. Try it back.
Okay. Well, that's much better. Okay. I'd like to call the policy procedure and protocol committee together. And four items that we're going to bring up that's on the agenda is the RN paramedic policy, use of helicopter landings, IFT for ACTs, or where we're at with that, and then EZIO. There will be, I'm sure, other things that may be brought up at the end. But for the first policy will be Jamie, or the RN paramedic.
Yes, so basically all I have on that is that policy went out for its 30-day comment. The comments came back, there wasn't many. They were reviewed, the policy was cleaned up, and it is effective now, correct?
It's out now. The policy went out with caveats that any individual that's currently in a class, an RN paramedic bridge class, is not affected by this policy. Any class that starts between now and January 1 of 2018 is not affected by this policy as long as they graduate before January 1, 2018. Any class that starts that doesn't finish past January 1, 2018 will need to follow the recommended training that's online that accompanies this policy. We've added hours to the airway and EKG interpretation, which are two areas that we found through our performance improvement analysis statewide that we felt that RNs needed a little bit more attention. EKG interpretation and intubation. So basically that's it. Everybody's good for this year. If you start a class in December and you graduate, say in February, then you'll have to teach that class according to the new policy.
Do I have any questions or comments on that? Okay, second item. Second item on the agenda for this committee, it's on. That was on.
Muted.
Thank you. All right, second item on the agenda was the proposed change to Protocol 9105, which is field aeromedical. And the issues behind that were agencies being able to use helicopter landing pads that were based at hospitals without going into the ER, simply using that as a landing site. So Janie sent me some information. We looked through all of that. It is not an EMTALA violation. It doesn't appear to be a violation anywhere. So what we added in was item 10 in the field aeromedical use of helicopter-based landing pads. It permits you to use that in cases where it's more practical and safer to do so versus a field-based landing zone created on or near an incident. You need to develop an MOU with the hospital to do so. And I have a sample of that, and this is out on the table, a copy of the proposed protocol as well as the a sample MOU that my department has. with WVU. The hospital needs to be called and or contacted prior to use and permission given to use that pad so that you know that they don't have anything incoming. You are not required to enter the emergency room if you're simply utilizing the landing site for field operations, subject to the following. MedCom has been contacted and a patient assessment given. The patient has been determined stable for continued transport as evidenced by a patent airway, with or without an advanced airway adjunct, vascular access via IV or IO, a perfusing cardiac rhythm, and upon arrival, the helicopter is on the pad and awaiting, or the helicopter is in view, or you have communications with the flight crew that verify an arrival time of less than 2 minutes. So if you get to the hospital and something has delayed that helicopter, it's going to be better for your patient to take them inside versus waiting on a helicopter that may be an additional 15, 20 minutes. So you need to work that out with the flight team that you choose to use. Should EMS arrive at the hospital with the intention of simply utilizing the landing pad and the helicopter be delayed, you shall immediately divert to the emergency room for stabilization for your patient. So that's just added to the end to give a little bit of diversity to the crews to maybe use a safer facility to land at.
And it has to go to PCC, and it has to go out for a 90 or 30-day thingy.
So any questions or concerns with that?
Is there a thing about 2 minutes versus 5 minutes? 2 minutes basically means it's got to be on the ground, really, right?
No, it's either on the ground, it's
I
in
know.
sight, or they tell you they have a
2
2-minute
minutes is
ETA.
great, though. Everybody's good with it. They're gonna have to basically beat us there.
Time out, Paul. Get an ETA and stay on scene. Make it work, man.
Circle
Make
the
it work.
hospital while they're circling the hospital. All right.
All right,
That's on
so
video.
we'll bring this up at the MSAC, and if it goes through there, it will go to MPCC for approval. I don't suspect any issues there, but then it will go out as all policy and procedure and protocol changes do for 30-day comment and then become effective.
And the two parts this could come very important for is not only seeing to your local hospital, but also if you're going to cross state on some intercepts, if you ended up with a patient that was going to a tertiary care center that got, changed, it sometimes it's going to be easier to go to that hospital if we can get air evacs to land, if we can kind of do that versus on the interstate or on the road. So there is other ideas about that. So it's just a lot safer than trying to get everybody else together. Any comments, questions? See, that's pretty good on both of those. See, that's where we got policy out, policy done. Moving on, that probably doesn't need to be on there for the next one. The next question is brought up with Steve. See here, McIntyre?
Yeah.
Okay, and IFT for ACTs, class 5 medications, and it's between Dr. Mills and Steve McIntyre and others that are interested.
Paul, basically what we're looking for.
Why don't you walk on up and turn around just because it'll be the...
Basically what we're looking for is guidance. A situation came up just recently where we had a level 5 provider take a transport from facility to facility with written orders for fentanyl, 50 mics as needed. The EMTI, the ACT, administered the drug twice as per those written orders. At the end of that transport, a medical command QA was generated and sent down through that the ACT did not follow their protocol, that they were acting outside of the protocol for transport. That ACTs basically are not allowed to do anything but watch fluid between the facilities. Contacted Dr. Mills, and Dr. Mills was very insightful on the protocol, and I understand where he's coming from with the protocol, But in 2009, we made interfacility transport guidelines. We have levels 1 through 6. A level 5 drug, whether that ACT can give it via verbal orders in the field, I believe should be the same as a written order for an interfacility transfer. That's where we're having our disagreements here. C3 IFT, it was an above and beyond the level 4 field program paramedic. So you took the C3 IFT so that way you had a little extra. As Paul likes it, the little bump that gets you that extra money. Dr. Mills would like us to do something of that nature for the ACT, to give them a little bit of an extra education to do an interfacility transfer. I'm just wondering if that is above and beyond what we really needed to do. We've already trained these ACTs. They're already trained. They're already giving the medications that we train them to do. What is the difference of a level 4 paramedic that just got out of paramedic class that chooses not to take C3IFT and does the transport to the hospital with morphine or with dopamine or with lidocaine, drugs that we're able to give as level 4 field providers? What's the difference than a level 5 that does not have a class right now that can give those same drugs that they've been trained to do? So we kind of contradicted what we had in policy in 2009, and I understand it's 8 years old. Things change, but it's a policy that we agreed to. It's a policy that we had adhered to. It's a policy that we trained these ACTs to. So here's where we're at right now. Are we going against what we put into there in that interfacility transfer guideline? And now do we have to have a separate class? And if we do, then that's something that we have to develop. That's something that we have to, to roll out and to train these 100 or so. How many ACTs do we have?
About 100.
These 100 or so individuals, which Charleston just put out a new class. They just had a class, so we've increased the number of ACTs. I understand that ACT is tentatively scheduled to go to the wayside. National Registry says, well, sort of, kind of. We had a conversation. So where do we need to be? What do we need to do with these ACTs? And it's something that I wanted to discuss amongst the group before we bring it up in the main MSAC meeting, if it's really needed to. Dr. Mills? What's your opinion?
Well, my opinion is that I inherited the ACT, and when I was hired, I was told that it was going away. Those of you that were on the protocol committee, we didn't even write ACT protocols because we were told that it was going away. The National Registry changed its mind and allowed it to continue on as a program, even though they don't issue a certification now, they will offer a test. So the state has allowed the ACT to continue to exist as long as the test is available through the National Registry, because that's the only way that we can ensure that the individual has the level of knowledge that they can practice in the field. Meanwhile, an ACT, according to the protocols and policies, has to call for medications administered through medical command. They are a 911 service. I think at the time that ACTs were developed, they were developed to be an intermediate between an EMT and a paramedic, because we didn't have enough paramedics. So the idea was to train them to manage airway somewhat and have some familiarity with the pharmacology and the drugs that they were going to administer, but not have the permission to administer the vast majority of the drugs unless it was a cardiac arrest situation. At that point, they could intubate and use the cardiac drugs in order to resuscitate. Meanwhile, the the paramedic protocols have changed, many other medications have been added, and the EACT still has to call for an order to administer that medication, and they have to call through medical command. Now, medical command is it's a legislative rule. Chapter 64 CSR 48 says, medical command physician, once notified, assumes full responsibility and all medical legal liability for said patient. So if you have that protection medical legally, and you have a cap on malpractice based upon the legislative rule, legislative rule doesn't say that Dr. Mills can write an order when he works at Princeton Community Hospital, and you can follow that order. It says that you must contact medical command, and therein lies the catch-22. Currently, our policy states that medical command has to be notified. As such, because an ACT is not able to independently administer the medication or critically think through the process, when you have an interfacility transport, it's entirely different than 911. An interfacility transport occurs whenever a patient is brought to a hospital and has had a medical screening exam and has deemed to have a condition that requires a higher level of care or higher level of management, and thus needs to be transported to another facility. It's not 911. It's why we have C3IFT, it's why we have CCT, and that's why we have some medications that paramedics can administer. Now, level 5 drugs, I can't bring it up on my iPad, unfortunately, but I looked at it, and the one that I could find was that ACTs could manage a lidocaine drip. But just because there's a legal issue here that worries me, and that legal issue is that they're following somebody else's orders, number one, because they're supposed to call it medical command and they're not. I'm a fear that it may lead to an agency medical legal issue. And lastly, I got to take it to the Medical Policy and Care Committee to get their feeling on whether or not they want to move forward on that. Remember, your doctor, your agency medical director is the one that is going to take the hit for you on any of the things that we do. I know that we all kind of forget the fact that y'all operate under the license of a medical agency medical director. And ultimately, when you screw up, if there's a lawsuit, the agency medical director is going to be the one that's going to be nailed for this. The agency will be nailed, the regional medical director will be nailed, and ultimately the state will be nailed. So I need legal input on it, and I need MPCC's input on it. And that's kind of where we're at, and that's the rationale behind what I think about interfacility transports at this point. If we can get it past those two entities, then we will. I see a hand. I'll shut up. Go ahead.
Dr. Mills,
That
the
would
only
be
two
Tracy.
medications on the interfacility transport list that EMTI cannot administer in the field in an emergency setting is fentanyl and morphine. Every other medication that we place as a 5, they don't need orders even through medical command to administer as a drip. We could pull the protocols up and the C3 list. We did all that forward thinking in 2009. Fentanyl push, morphine push, because of the narcotic issue, they have to have an order. But every other medicine on the list is equipped. The protocol doesn't make them call until after it's initiated, and they can transport.
Now, unfortunately, Tracy, I don't have my protocol manual with me, but if you're talking about magnesium or cardizem, cardizem's not listed in that group. Versed, I don't believe is listed in that group. You tell me, because I don't have it with me. But there are several of those drugs that we don't have in the protocols.
Here's your list.
That's your C2 ST listed.
That's the, yeah, that's not the one. That was the 2000 and, this is the July.
Yeah, that's the old one.
The July one, the November one was the last one that came out.
November of 9.
2009. There were two, remember? We looked them up the other day. And the first one was July or June or July of 2009. The second one was the big, long list that was supposed to go, posters size that was supposed to go to the hospital.
There's your November one. Now, I apologize for old eyes. My eyes are just as bad. But that is a little bit bigger, or a little smaller.
I am disappointed. I would have sworn that Paul would
Many of these books aren't even on the formulary at this point.
November 23rd.
How many, could I get a quick straw poll in here? How many people have agencies in their areas that have ACTs now or are looking at doing that? I know that the numbers are growing, but we've got
We started
a
off,
substantial number that it is becoming that.
Paul, this issue, I mean, it's affecting multiple agencies. There was many agencies that were doing this prior to, and I don't mind being the scapegoat here, that my EMTI was called out on it, but there's many agencies that were utilizing this. Since this happened, this has put a big stopper to interfacility transfers. This is causing issue to the smaller hospitals. They can't get a CCT and they can't get
Well, we're
their
trying to
ALS.
take care of that by allowing a C2 IFT, which will free up a lot of folks and will allow a CCT person to be in the back of an ALS ambulance. However, let me read these drugs to you. Fentanyl, morphine, you got a call for an order for that. The next one down there is lidocaine, that's an ACLS drug. Furosemide, maybe, that's one that you can give. So that one you can transport. Ativan, we don't even have that one anymore. Valium, we have maybe rectal Valium, but we're using Versed. That's line one, second column. Atrovent, obviously breathing treatments. Moving on down, epinephrine, 1 to 10,000 bolus, that's a cardiac drug. And cardiac dose. And Narcan and D50. Those are the drugs that are scheduled as stops. Don't see applied for tenormin. Well, 6 nitroglycerin, obviously, but again, that's a cardiac drug. Procainamide is not. Umex. Half these aren't even on there anymore. Digoxin, Plavix, Phenobar, Dilantin. Even Zofran's not one, even though we bumped it up. Captopril, Clonidine, nitroprusside, metoprolol, nicardipine, labetalol. None of these are fives.
Sure.
So
We're not asking for that.
So that leaves you with fluids, lidocaine, and maybe D50 if you need it en route, but.
The biggest problem is coming up though is pain management. Pain management is huge for interfacility transfers. And if you have a level, you have an EMTI that can give pain management in the field with medical command orders, verbal orders, what's the difference than that same physician in an emergency department giving a written order?
CSR 482.28. The medical command physician takes full responsibility for the patient. It's a 911 system. It's within the 911 system. Again, I'm not saying no. I'm saying this has to go before the guys that have to pay the malpractice bills, and this has to go before legal. I mean, it's just as simple as that. We've not done it before, at least we shouldn't have. And now you're gonna have some that we allow facility transports that need pain medicine. Okay, well, what if they're on a Cardizem drip? They can't take it, whether they need pain medicine or not. What if they need another drug that's not on that?
It'd be on their scope of practice, though.
Exactly.
This is within their scope of practice, other than what you're citing there in 64 CSR.
So if, at this point, they have to call for a narcotic, what you're asking is that under certain circumstances, if I'm on a 911 call and I've got a broken leg, I gotta call my medical command doctor. But if I'm en route between facilities, then I've got to call somebody else. But it's not written that way, you know, in the 64 CSR. I think they will rule on it.
I just have a question, Patrick. So if you don't call medical command, if that was a written order, then is that the local, their ground EMS service medical director and that ER medical director, do they have the liability then? Does that create that liability, limited liability, because it's not going through medical command?
It's in the facility transport, CCT and C3IFT and paramedics are allowed to take in facility transport through policy and through our legislative rule. ACTs have not traditionally been allowed to transport emergency patients in facility transport patients because they have to call for all of the drugs that they need to administer including except cardiac arrest and cardiac arrest. So if you take an order from a non-medical command physician, you are not, in my opinion, and I could be wrong because I'm not a lawyer, that's why we need a legal opinion. If you take that from a different position that's not protected under this legislative rule, you may not be. However, and that's simply because of certification. It has anything else to do with CCT folks. The trick becomes if you're a CCT individual and all of a sudden you're doing chest compressions on patients. And are you declaring emergency condition within your facility and it's only,
Well, we used to have a protocol, 9283. It's now the LVAD protocol. Okay.
They're covered on this. What covers class 4 transports now? Because I couldn't see anything in the protocol that says if a physician orders me as a class 4 paramedic to give more than 10 milligrams of morphine during transport, and why wouldn't I have to call medical command for that?
because you're allowed to take in facility transports and you're allowed to manage that drug, you don't have to call medical command for every drug that you take. And yeah, it may go above and beyond that, but you do have the ability to do that since paramedic level training is high. You understand the pharmacology of that.
Okay, I just didn't find anything in the protocol that said I was allowed to do that.
So is there a protocol that says the ACT can't do an IFT?
Traditionally, they've not been allowed to transport.
But there's no protocol. I'll just say as a region, as a region 1 medical commission, I see how long it takes to get ambulance, IFT transports, transports out of the hospital to the patient. Just poses the question, if ACTs can't be a part of that moving of the patient, there's going to be an increased more of a delay with moving those patients out of the hospital. Correct? I mean, I'm just, logic would dictate that.
We've changed CCT transport
So the agencies that are using ACT, we're now saying that they can't do IFTs. You want them to stay back. So we'll send our higher trained paramedics to do the IFT transports, so the ACTs in the communities which is fine with, but I just think that that's, I just don't understand I don't understand the reasoning behind why an ACT can't do that. I haven't seen a protocol that so if the patient, well, you're okay with them dying in the ER because we can't move them? Because that's what you're saying. So basically, they can't give, what's the, you're saying that you can't give more than 10 milligrams of morphine per protocol, right? That's per protocol. But the physician can write him an order for as much as he wants to do, and he can take that. And then your logic behind the ACT can't do this because it's outside his protocol. So I agree there needs to be a legal interpretation of what we're saying here, because I do think you're right that there is something that's not. We need legal clarification, but I guess I just don't get it. If these guys can just start the lines and they can hang the drift and they can do all this in an emergency setting, but they can't do it on an IFT transport, and we should delay care, delay transport when the facilities are already waiting, this is a waste of time to get these patients moved. We want to add another level, and he's right, pain management is, it's one of the number one things we need to do.
Did I say we're not going to do this? Did I say we're not going to do this? Because you're acting like I said this will never happen. Am I correct in that assumption?
You're contradicting your statements by saying all right.
That's fine, Doc. But I'm just saying, you can't say that, oh, because of protocol, they can't do this, but then say the same thing up to the paramedic that would be outside his standing orders and protocol, that he can't. That's called, we do need to get a legal opinion. I'm just simply asking a question. I think there has to be a role for ACT and IFT to continue to expand the state regardless of whether or not this state office wants that to happen or not.
Did I not say that?
Yes, sir.
So it's a legal opinion.
The other thing, I'll reiterate that every medication on the medication approval list that you can do as an IFT, as an ACT, every medication you can do in the field without an order, except morphine and fentanyl. We just verified all of it, sitting back here. I wouldn't have done it beforehand because I didn't think too much about it, but coincidentally, it was Dr. Newman, a C3 IFT committee, and they forward thought enough with the existing protocols. So you would think they would have to call for adenosine, they don't. You would think that an ACT has to call for lidocaine, they don't. They don't have to call for amiodarone. So they really, truly have.
Exactly, but do you know what protocol you're talking about? The cardiac arrest protocol.
Correct.
Correct. That's the only time in the life of an ACT that they can give that medication without calling the doctor. It's in the cardiac arrest protocol. Look at it, it's in the cardiac arrest
So
protocol.
let's do quid pro quo. Patients at Plateau Medical Center post cardiac arrest, and we have to get them to Charleston. But because they can't monitor what they initiate, we can't do the patient. That's reality for us right now.
How many times do I have to say, I'm not opposed, I have to go through the process?
What is the exact wording from CMS according to reimbursement for this? If we allow the ACTs,
It may self-correct in that CMS right now is looking to deny reimbursement from ACT because it is not the level of the paramedic. They don't have a level of training, and so that is another reason why this may be a moot point. If CMS decides that they're going to lower the fee for a C3 IFT, I'm not speaking to an ACT or a C3 IFT, or even talking about the C3 IFT.
All right, so at this point, we're not gonna make a decision here today. There's nobody here that has the authority to do so. So I move, we turn it over, we get a legal opinion, and it's gonna have to go back to MPCC anyway. So we bring it up at MSAC, we make a motion to send this to MPCC, and we let it be dealt with the physicians. Maybe we can have a legal interpretation before it gets there.
All right, and in that motion probably at the MSAC, there's three things I think are here. One, the last point first was about whether it's an ALS level. As far as I understand CMS, it just says that if you have an interfacility, they have to have training beyond the level of ALS per your state protocols or guidelines. So I think that part's going to be involved with that. Number two would be the fact about what medications they can give. The other thing is that these ACTs are not only transporting people from a lower level to a higher level, but there's also a lot of them that are going from a tertiary care center on hospice or to home that have pain meds, 1 milligram morphine every hour, because most of them are cancer patients going back. And that's a huge number of these interfacility transports that would currently have to be utilized at a C3 level or paramedic level that could be in the community if they can do that. So it's not just people that are critically ill going up the ladder in rural areas, but it's also in those areas that have already been treated and going back down. But that will need to be turned over to MPCC. That motion will be made by someone there out in the, from somebody on the committee here, and then we'll look at that further. Any other comments about that? Hearing none, let's move on to the as far as. But listen, I want to comment because people were commenting about this exchange. But I think that's exactly why we formed these committees. Because before we were in MSAC, right? We had an hour and a half, or 2 hours. You couldn't have that exchange. I think that the fact that so many squads came to bring their points directly to, and Dr. Mills, it pleases me that he walked straight back to those agencies and spoke one-on-one. So this hour is devoted to getting that one-on-one time that you may not get somewhere else, or having to come in one at a time. So I think there's value in doing that. And so it may not affect you in your agency right now, but for those agencies that do, one of the things I think is good about it is that we do get this opportunity, and that's a rare opportunity to be able to address things directly. And I appreciate Dr. Mills doing that so directly and finding out, and hopefully we're working towards a solution that obviously it's going to require some work. As far as protocols, now, so we are at 20 minutes tail. The agenda items are there. Do you have other issues that are coming up? Or one thing I want to throw out is there a form, and I don't know it, if I wanted to change a protocol or introduce a protocol, is there something on the website? We talked about it at different times about how I would, or any agency would do that process, and I think that would be something that would be valuable. Do we have a...
So, speaking along those lines, Paul and I talked about it. The process has been that everybody could have input in protocols and procedures and that type of thing. And if you wanted to change a protocol or add a protocol, you worked in another state and they had a protocol that was really effective, that you could present that to MPCC, send it in as a suggestion. A lot of people are caught up in how they do that. So Paul and I talked about developing, again, another form that we could put on the website where you could submit, using that form, a protocol change, a new protocol, a protocol deletion, whatever it may be. And then those would go, we would send those straight to MPCC. They look at those at the beginning of every year and then decide what they want to put out, what they're going to agree to, not agree to, what needs to be changed or tweaked in them. And then those protocols are then reposted. If there are significant changes that need education behind them, then the office and Dr. Mills will do a video that will come out with them as an education tool for the new protocols. Most of them to this point have just been very minor changes here and there. And those can come out just in an outline of what changed, but major changes, again, will have a video attached to them. So I think the big identifier here is what's the process to do that. If we create a form that can be submitted to MPCC, that's probably the best way to go with that. Then everything's in writing, you can put attachments with it and whatever may need to be at that point.
I thought there was already a form in the protocols.
I thought there was too.
There's already a form in the protocols.
In the protocol itself?
Yes, there is.
It was too.
There is a form in the protocols.
To submit changes?
Mhm.
There's an option.
There is.
was.
I don't think it's in the protocol.
There used to be. There already was a
Okay,
form. in
does
the
everybody feel
protocols.
that's there? Let me throw out a quick example. So you got the child in the car seat, you got the athlete, and whether you're going to use you want to add a line and say under heat stroke that if it's an athlete, you need to cool rapidly one option could be to put them into an opened body bag with ice water, you know, to contain that for 15 minutes and reassess. I don't know. I'm not sure if that's ready for MPCC. I'd like to bring it up to this group, you know, and say, well, does that make sense from what you're reading in EMS World and gyms and everything else? Because a lot of that kind of goes up or down. I don't know if it needs to rise to the level of that or not, but if I was going to submit something like that right now, I guess however we get this form, either it's there, or we re-put it there, or we get it on the website, that would be some way I could do that, put the research articles in there, try to get feedback, because I don't know if it's going to work. It may make a big mess, it may not work at all, you know, I don't know whether that challenge is there, and that's just one small line. But I think that process is there. So do you think, and I'm going to throw this back to Jamie and Dr. Mills, so do you think that those would go straight to MPCC, or is there an avenue where they should go to MSAC? I'm not talking about the major changes. I know MPCC is the only ones with yourself that could change the protocol, but is there part of this committee where people could bring up, you know, is a first pass of getting it out? Do you see value one way or the other?
What's happened in the past 4 years is I get an email, and
Right.
then I forward it on as soon as I get it to MPCC and give them time to look at it. If there's any attachments with it, and most of the time there are, and then we discuss it at the MSAC meeting and decide what we're gonna do. Now, if you want to complicate,
I don't want to
that,
that was my thought. Originally I thought, wow, this group here, we could bring up ideas, but maybe it's more of an idea, this is just a forum to bring up ideas. If you're going to do it, why are we putting, as Shane would love to say, put another step in every step we have? So maybe we'll just not do that. That if things are brought up during this committee, at the end I'd like to have 5 minutes for anybody that has protocol thoughts, but that's more if you haven't fleshed it out, the policy would be submitted appropriately either to Dr. Mills by email now. If there's a better, well, whatever, more concise form, that's fine. That would really be up to him and there. Does anybody have a challenge with protocol submission, or maybe that seems pretty straightforward? Some of us, I guess, knew that all along. Some of us have forgotten that. I don't know where that form is at or what we do with that.
There used to be a form in the protocols. There was a way to submit your, there now.
I would never question you that there was. I'm not sure it's there now, but we'll need to get it back.
There used to be.
There, yeah.
Even just general form.
There's not one there right now.
No.
I'll check all your pages and stuff.
Somebody, then it was taken out
Yeah, it's not
because there
there.
was a form in there.
I inherited the 2012 protocols, and there wasn't one in there. So it had to have been before
We have
that.
some of the 2009s printed off, we'll check that and see if it's in the back.
There was a form on that one.
I think it's the oldest one that we have. And if we do.
I'm not telling my age, but I know there was a form in there.
Yeah.
Come on, Karen, I know there was. I knew there was a process to do that.
They were gonna stay.
Does anyone else?
Don't feel bad, I remember.
I know, that's what I'm trying to figure. What's that? Can we work on that? I don't know what we can do. Does anyone else have anything for the good of the order of the policy, procedure, and protocol? We are 15 minutes ahead, and as we know, we have training committee at 12 p.m. Could be 12:15. We get up. There's no way we're all going off the hill and back up. Anything else for the good of the order? Okay.
Do you guys want to start training committee a few minutes early?
Yeah, that sounds good.
We're hungry, Bowie.
I know. Thank you, Bob. That's what I thought.
Take care of his phone.
I know that there was a process to do it.
Because we didn't parcel. Take care of him. Bring him
Yeah.
I'm hungry.